This chapter is about schizophrenia and the spectrum disorders as well. I'm going to have many slides with a lot of information on those for you to look at and review, and I'm only going to have to speak through a few of them because most of the information is on the slides, so you'll just see the slide. You may not hear me talking very much about much of the slides since the information is there. When we think about schizophrenia, many times individual may be functioning and seem like anybody else, but over time they start to deteriorate in their abilities to take care of themselves and to be able to function in everyday life. Typical onset is usually in the late teens and in the early 20s. It has occurred in young children, but it's not something that you normally see. And again, it can begin in later adulthood, but the average is late teens, early 20s. With epidemiology, it doesn't decipher any certain race, socioeconomic status, culture. It can be random at any time. So there's no certain type of individuals that we look at for this diagnosis. There are some things to do with this, such as comorbidities. When we look at comorbidities, one of the ones that they look at are substance abuse, nicotine dependence. Many of them will want to smoke and have that cigarette. It helps to calm them. They'll have, they're very anxious, maybe become depressed, maybe suicidal because they hear the voices. They feel like everyone's against them. Their health can be affected because they're not taking care of themselves, and they can have the polydipsia as well. This slide is interesting because they show a patient who has schizophrenia who is never medicated, and you're looking at the blood flow on the PET scan. On the other is a normal brain and flow with brain activity, and so you see the unaffected areas. It's really interesting to look at the two brains. Look at all the green matter. In the phases, you have three phases. The first one is the acute. This is where you have the onset or exacerbation of symptoms. In phase 2, this is called stabilization. The symptoms start to diminish, and there's some type of movement towards the previous level of functioning. Then phase 3 should be your maintenance. This is at or near a baseline functioning. And that's where we want to get them back to when we go through these phases. During the pre-psychotic phase on your general assessment, you're going to see positive symptoms. You're also going to look out for negative symptoms, cognitive symptoms, and affective symptoms as well. Your positive symptoms are going to be an alteration in thinking. So they're going to have delusions, where are your false fixed beliefs. They're going to have concrete thinking. This is the inability to be able to think abstractly. As far as their speech, they're going to have clang associations, word salad, neologisms, and echolalia. So when they have a word salad, they are going to just jumble words that are actually meaningless. So they may just throw words together that make no sense at all. Car, house, rides, your book, glass, store. And you're like, what in the world did they just say? That is your word salad. When you have clang associations, they're going to say like knick, knack, paddywhack. And so they have just different little, cling, clang, clinky, clong, whatever that may be. Then sometimes they have neologisms, and these are just made up words, just a word they make up. So when they're talking and they're using these words, and you have no idea what in the world they just said. They're using a word and then using a sentence, and they throw in this word, and they've made it up. And then echolalia. So they may say, it's time for supper. Time for supper. Jack, pick up your books. Pick up your books. Pick up your books. So that's some of those examples. Your textbook also lists several other disorders in thought and speech, and I'm going to let you look at those. And those are page 206, and then go into 207. In 206. So look at some of those, and some of the examples of those that are not the ones that you're going to see all the time, but you will see some of these. Some other positive symptoms are alterations in perceptions. So they may have hallucinations, and hallucinations can be auditory, or maybe a command, or visual. This is the last slide on the positive symptoms. And so sometimes they may have behaviors. Maybe they are catatonic. Maybe they walk and then they just stop and they just stand like a statue. And that can be your waxy flexibility. They may have impaired impulse control. Negativism, doing opposite of what is requested. You tell them to sit down, they're going to stand up. Negative symptoms have to do with the loss of normal functioning that we see in people every day. Affect, this can be unusually blunted. They have a narrow range of normal expression, or they are very flat. Their facial expression never changes. They can also have inappropriate affect, or very bizarre. When it comes to apathy, they may lack emotion. Avolition, this is the lack of motivation in activities and hygiene. They may smell, their hair's a mess, their clothes are a mess. Anhedonia is the lack of pleasure or joy. They find it nothing, even in things that they normally did. They also may have inertia, lack of energy. And so they don't even want to do anything. They just sit around. They're very concrete in their thinking. They can't think in the abstract. Cognitively, they can't hold their attention well. They can't remember very well at all. They have difficulties with their cognition. One minute they might be able to cognitively think of something, and then they just go off somewhere else. They can't keep their thoughts together. So here's some also things that you want to think about is as far as their assessment for depression because of their affective symptoms. So again, you want to think because of their depression, it can lead to some of those comorbidities, such as using drugs, substance abuse, because they're trying to get that feeling away. They don't like it, and so they will self-medicate. Many will try to commit suicide. They maybe hear the voices, or they just can't take it anymore. They're tired of the medication. They, it's become unbearable. It also, when you're depressed, it does impair your everyday functioning. So again, and a lot of times they're afraid of that relapse. What's going to happen? What are they going to do? And so, where do they go? Another affective symptom can be psychosis, and this is those mental changes. Again, they have those delusions, hallucinations. They can't think in an organized manner. They're just kind of off the wall. They're very hard to carry on a conversation and try to get information from as well. So here's a list of assessment guidelines that you want to go by, things that you want to ask and that you want to assess for. When you're thinking about nursing diagnosis, you can also go by the symptoms. So you can look at the positive symptoms and the negative symptoms and kind of come up with your nursing diagnoses that involve those symptoms. Even when we're planning our outcomes, we can go by the phases. Phase 1, 2, 3. Remember the acute, stabilization, and maintenance. So in acute, again, we have to think about safety. This is when they're full-blown, and so we need to think about getting them stabilized with medications, keeping their medications also stabilized, and keeping them safe. And then in phase 2, here would be our outcomes, or if they're in phase 2, these are our outcomes that we want to reach. And we can do the same thing with planning, looking at the different phases. So when you think about your interventions, you can go by the phases as well. So in the acute phase, we're going to try to get them back on their medications, get them some type of evaluation. We're going to give them support. We're going to start their treatments, make sure that they're supervised. We're going to give them an environment of milieu therapy, so it's a welcoming environment where they're comfortable, and increase their fluid intake because they need those fluids. With the stabilization and maintenance phase, again, we're going to making sure that they're keeping up with their medications, that they are talking and communicating with their healthcare providers, and we're trying to come up with some type of services in the community so that they can get back out into the community and out of the facility. Also, too, we're going to be, as you're working with the therapist or while they're in therapy, they need to be talking about their hallucinations, their delusions. We're going to look at the associative looseness. And then we're also going to start working on health teaching and promotion so that they can keep in that stable maintenance phase and not go back to the acute. A couple of things that you want to think about when they have a delusion, that is a fixed thing that they believe in, and so you're not going to change their mind. So it doesn't do any good to argue it. So you want to focus about their feelings about it and what's going on, but don't try to change that delusion. Also, make sure that they're safe, especially when it comes to if they're having hallucinations that are telling them to do something or to harm themselves. One of our major or priorities is their safety. Try to help them to think about more about reality. So start just trying to get them to focus more on reality and what is real and what is in front of them. What triggered this? Maybe look for different symptoms that are triggers for them. Help them to understand and try to be empathetic and genuine when you're talking to them and helping them deal with these issues, because to them it is real. Encourage them to keep up with their medications and to stay on schedule, and what side effects to look out for the medications and how to keep up with them. Here's our, remember when we talked about the antipsychotics, we have our first, second, and third generation medications. So start trying to jar your memories about your medications. Here's our first generation antipsychotics. They're also known as your typical medications that you're going to see. So you're going to have your dopamine antagonist. You're going to look at these meds, because these are going to look at if you have a lot of positive symptoms of schizophrenia, your target meds are going to be these medications. And then you'll see the advantages and the disadvantages of these medications. Your second generation are going to treat both the positive and the negative symptoms. And again, if the extrapyramidal effects or the tardive dyskinesia is an issue, so you might want to move towards the second generation. Of course, some of the disadvantages, and one of those is the weight gain. And then here's some of the medications listed here. And then we have our third generation antipsychotic, and this is that dopamine stabilizer, Abilify, and it improves both positive, negative, and also cognitive function. And as you see here, here's some of the dangers, potential dangers with antipsychotics, some of the side effects, and I have those listed here. Sometimes they need other medications along with their antipsychotics, so they may also need some type of antidepressant or some kind of mood stabilizer to help them with what other comorbidities they may be having.